The role of digital in primary healthcare.
Thanks everybody. So today we are talking about the role of digital in primary care. So we have some clinicians, some leaders across healthcare today, and we're going to be talking about patient-facing technology, the importance of prevention, virtual wards, making life better for staff, and of course AI. You can't go 2 seconds at the minute without talking about AI, so we are not going to disappoint you there. We'll do some intros to kick off. My name's James. I am an anaesthetics and intensive care doctor by background. I practiced clinically for 5 years. I've done lots of different things in leadership policy innovation in the NHS in the UK. I've run a couple of health tech accelerators, but I'm the co-founder and CEO of SomX, and we are a communications and creative agency for health tech and biotech companies. I also host something called the Health Tech Podcast. It's 5 years old as of last week. We've done 300 and something episodes. And I've got Health Tech Pigeon as well. So if you want to stay on top of the health tech news, just Google Health Tech Pigeon. There's only one of it. It's a newsletter and a podcast, a panel show. But I'll hand over to my guests to introduce themselves one by one.
My name is Pierre, Attard, Managing Director of TL Limited. We are an IT solutions provider in Malta, focusing mainly on digital health technologies, providing electronic prescription, national electronic health records for the government and even for the private healthcare industry.
Thank you.
Hi, good morning, everybody. I'm Roseanne Camilleri. I'm the Chief Executive Officer for the Primary Healthcare Ministry for Health in Malta. We run 10 health centers and community clinics and center of excellences, and we're moving on towards introducing also AI and with our electronic patient record systems.
Exciting.
Good morning, everyone. I'm Masood, Nazir. I'm a family physician in the UK. I've been a family physician for about 27 years now, and for about at least the last 22 years, I've been looking at digital tech to help clinicians. And I've done various roles in that time, from looking after digital primary care across the whole of England to now looking after even what I do in my practice. So hopefully I can share that, James.
Hi, everyone. I'm Dr. Joe Pearson, GP and occupational health. I'm here because actually I decided that we need to do more rather than just rely on the current medical services that we've got to try and affect change. I realised in occupational medicine we're looking at people who are getting sick and what to do when they were sick. Same in general practice. And when you look at what we try and do in Oc Health, we try and actually prevent sickness. And it led me to a belief actually we need to be doing things differently. And so I've teamed up with Fitbit, created a virtual ward to look at the indicators that make people sick, stop it from happening, just so that they don't end up going to see Masood and, costing our systems so much and costing the individuals so much. So that's, where I'm at now, prevention.
Thanks so much, guys. I'm looking forward to this because for people that, if anybody has ever listened to my podcast, one of the questions I ask all the time is like, how do you actually do that? And the practicalities behind stuff. I'm excited because you guys have actually done digital in primary care. You've actually changed things and you know how to actually get things done. So that's what I'm interested in talking to you about today. But I'm going to start with Pierre and Roseanne here. Because when we had our call previously, we talked about the fact that technology in primary care has always actually been quite a big feature with electronic health records, electronic prescriptions. The sort of digital infrastructure has always been important. So do you guys want to reflect on kind of how we've got to this point and the role of digital in primary care up until this point? Setting the stage for the likes of AI.
I'll set the stage. Primary healthcare moved on into electronic patient records around November, started to move in November 2019. That's just before COVID. So COVID was also providential for us. That Malta being small, everything we are used to go into the car and go somewhere or phone someone and go, easy reach. So the electronic patient record and COVID, they brought us into that quantum leap that we would speed up the process very quickly. We had 6 months. It was part of Converge. Converge is an EU-funded project, a 5 million project funded by the EU. It was part of Converge. We had to introduce the electronic patient record in 6 months. We had the unions also to deal with while we were doing that. And we managed to move into, we remove all the manual files, all the physical files, move all of that onto electronic systems, train our staff. Our staff embraced the electronic patient record systems, the IT side of it, because they didn't need to deal with papers anymore. And so from there, it was, again, as I said, the quantum leap that we needed to get this on board all over primary healthcare, which, as I said, it's 10 health centers and a multitude of community clinics. At the moment, we're refurbishing them all. We have 26 at the moment going around all Malta as well. So we are now connected, electronically connected in real time. So wherever anywhere the patients choose to roam to, they have their electronic record accessible from any points within primary healthcare. We're also working on interfacing with Martindale, which is the main hospital in Malta. We have some interfacing already done, but obviously there are many systems that we need to interface to. And basically, this is something that's changed our lifestyle. Our lifestyle, the patient's lifestyle, things are clearer, easier to move, continuity of care is better. There's the legibility of writing and from the manual to IT because it's clearer. Doctors are not known for writing very clearly. So that hurdle is now something of the past. And we also have patients also have accessibility to the records through My Health. So that also gives the patient visibility of the results of their blood tests and MRIs. So yes, we managed to do quite a lot.
It's interesting, isn't it? Because you talked about connectivity there. You talked about one of the big advantages being that once everything's connected, and you even talked about interfacing with secondary care as well, but once everything was connected in 2019, it's not long until now you're very comfortably now talking about deploying AI and things like that, which we'll come on to, so the connectivity being so important. But Pierre, have you got anything to add?
Yeah, sure. As we were saying here, these are all touch points. Health is a data-rich industry. So when we talk electronic prescriptions, EPR, digitization, these are all data points where we need to have importance is always focusing on the patient journey. So going from primary, secondary, virtual care, this is something that every patient needs to have continuity of care. So the point is that all this data information goes into the idea that the government is working on the National Health Record concept. So this is structured data coming in from all these data points, and there will be one specific record where the patient can go anywhere, even internationally, not only in Malta, where there has continuity of care. That's key for the industry.
So moving on to you, Masood. When it comes to technology, we can put all the infrastructure in place and we can talk about fancy things like AI and even Web3, dare I say words like that, and all that sort of stuff. But ultimately, when it comes to primary care, there are some basic needs that need solving. One of our bosses used to use that quote that the future's already here, it's just not very well distributed. And of course, there's getting people up to a baseline of where a baseline level of digital activity will solve so many problems. Things like websites, just giving patients digital choice, telemedicine optionality, things like that. What's your view of like the importance of just getting this baseline level of digital in primary care to get things right?
No, thank you, James. It's interesting, the journey, having been on this journey. I ended up doing digital almost 22 years ago because I was the youngest partner in a practice. Everybody else was afraid of digital. So I'm just saying 22 years ago, the only thing you did digital in a GP practice was you added blood pressure and you printed a prescription. Okay? Now, what's the value of a printed prescription? The value of a printed prescription in my case is I don't get the return by the pharmacist or the patients. I'm not embarrassed because I can't read my handwriting. You know, imagine that a patient goes to the pharmacy, they can't read what you've written, and you get it back an hour later saying, can you explain this? Now, digital made that easier. That's a really good thing. So at a basic practice level, I've spent the last 22 years trying to work out what I can do to make it better for patients, safer for patients, which is they get their prescription, they get the right thing, but also how can I get the staff in my practice to also use the technology. So one practice, I look after a 30,000 patient practice, 130 staff. I cannot do digital in the practice unless everybody's on board. Okay, it doesn't work. Otherwise, dual processes are running, inefficiency, no productivity. So there's a lesson to be learned. Digital is not as easy as opening your smartphone, switching it on, and it'll work. There's a huge amount of effort spent trying to bring people on board. So don't remember that. That's really important. Over the years, I've been responsible for 7,000 practices in England. So my responsibility was the 7,000 practices across England. How did I get them to do digital? I could have put it into contracts. It's fine. You put things into contracts. But what I had to do was listen to what was the right solution. Many times suppliers offer you a product and they think it's the right thing for clinicians and patients, and it's not been thought through. So I spent a lot of time talking to patients and staff and saying, what do you need? What are you ready for? And taking a stepwise approach. Okay? By just switching on appointments for patients electronically doesn't mean the system will work when there's not enough workforce, enough people, and people don't know how to use it. So it's really important. We were able to send prescriptions electronically. Look at what Pierre and Roseanne have done. We could do that for years, but the patients wanted their green piece of paper. They were familiar with it. They wanted to walk out of a doctor's room with a green piece of paper. It took a pandemic for that to disappear. Okay? Otherwise, I used to regularly get reported to the MPs and going, why are you not giving me my green piece of paper? And the pandemic said, no longer can you have a green piece of paper. And therefore, it took something like that to change that behavior, because it was an expected right. Okay? So it's really important. So when you do digital, think about what are you trying to do. There are many people, the staff who work in these practices, it needs to make sense to them. If it doesn't make sense to them, it will not make sense for them to engage patients to do it. So it's really important. Make it simple. And invest in training. As well as the solution, invest in the training. So I think it's probably key messages, James, is think about what the patients want and why patients should do digital. How does it make their life easy? Don't force it upon them. Give them choice and listen to them. And secondly, listen to your staff. Because if it's going to make their life easy, I look at my life now, it's complicated, and I'm sure Joe will tell us, Joe will tell us how important it is to look after your teams and their work and the workforce. If you've got no workforce, you can't deliver primary care at all.
Let's touch on that now then. So in terms of us thinking about new technologies, and you've addressed so many of the challenges of like actually adopting it and getting your team on board, etc. But how important is it that those technologies benefit not only patients, but actually staff themselves? It's actually, I found it in my career in health tech, it's quite difficult to build a business model around actually helping staff first and foremost. It is quite difficult to do so, but how important is it? Because ultimately, you know, you ask Richard Branson, it's all about, you know, train your staff and they'll look after the customers. Look after the staff, they'll look after the customers. Do we think about that enough in healthcare? And when we're talking about digitizing primary care, how focused can we be on staff and how focused should we be on staff?
Well, I mean, yeah, from my point of view, it's interesting because in occupational medicine, I deal with a hospital and I'm looking after the staff. COVID has decimated them. You know, a third of GPs are planning to leave in the next 5 years in the UK. That's colossal. The health needs on those general practices are growing. The access to secondary care is diminishing. I'm talking to consultants who can't even climb the stairs now because of long COVID. And part of the moral injury they have is they're now tasked to send back a proportion of their referrals back to the besieged general practitioners. Masood, I mean, kudos. It's a Sisyphean task you have. And this is what makes me think we should stop making people into patients. We should be sending or going upstream here. What makes people sick? The highest reason, or the biggest reason people come to see Masood, anxiety and depression. Second, ergonomic back pain. But the biggest thing that makes people sick is diabetes and cardiovascular disease, and these just don't come. And they are extraordinarily devastating for health services and the individual and the companies they work for. And my view is we should be looking at this. What makes people sick? And we did a trial with the truck drivers and the people who worked there. They were sedentary, terrible diets, high level of cardiovascular disease, diabetes. We onboarded them, and then we put them onto a Fitbit, and we just touched base with them every week, and we shared their ongoing data with their partner. Now, that partner doesn't want their husband or wife to die or get sick, as they are doing in the haulage industry. Average age 56, average age of death 63. We rely on these guys for everything you're sitting on, you're wearing, you're eating. But these guys are getting sick, and their bosses say to me, I know they're sick, I know they're unwell, but their health is not my concern. I say, well, actually, it is your concern. Legally, it's your concern. Morally, it is. But financially, it is, because your business will go down. So I think if we can plug that idea into corporations, individuals and their families to say, listen, ill health is not inevitable. Do not think because you're sick you need to go and see these guys. Stop yourself from getting sick by just doing the basics. And we found actually that we can stop that from happening. We brought down HbA1c, we brought down cholesterol, blood pressure, average weight loss 5 kilograms in 4 months, and none of them got to see a doctor. It didn't take an awful lot. It took will, and it took corporate health culture change. And that's where I'm looking at now, James. I just think really we should be thinking beyond the model we have, which is being exhausted by the health needs that are ever growing and the healthcare provision, which is ever diminishing. And we're part of the solution. We are not the solution. Everyone here has a part to play. But I'm just looking upstream, scalable, cheap. Let's stop people getting sick.
So, thinking about that solution then, I'm conscious we're running out of time remarkably already, but virtual wards, arguably somewhat what you described with the Fitbit. We can extend that into more of a virtual ward thing in your mind if you wish, but also Roseanne AI as well. Practically now, if we're thinking about solutions to realize some of what Joe is saying, what Masood's saying, what you guys have said, how are you approaching that very practically now in Malta, getting AI into primary care?
Yeah.
What can we all learn here?
We're still at the outset of the AI, but we're still at the initial stages of the AI, but we're looking at three different aspects. One is because primary care is also responsible for the National Screening Center, where we have we screen for breast cancers, we screen for the colon cancer and cervical. So we're looking at algorithms, we're talking with international institutions, and we're also in touch with different programs to see how algorithms in breast screening, AI algorithms, can be adopted so that we would make diagnosis easier. That is something that we have started on already, and we hope that we will be moving towards even participating in programs. Being a small nation, we are an interesting study, because you have the whole nation, a study of a whole nation in terms of figures. So it would be interesting to participate with what we have at the moment and compare with other countries. We can do this because recently also through the electronic patient record IT system, the same thing, we have connected our systems with the IT system of the national screening, and connected the national screening with multi-day hospital as well. So we have the loop, it's already in place, so we can do a lot over there. We're also looking into AI for ECG, for the 10-lead ECG. We're moving on that as we speak. That would give us a lot of opportunity, because ECG technicians are not really available. They're a dying breed. We have 10 health centers. We need 10 to be very effective, and they're not available. So basically, ECG is by appointment. So with an ECG 12-lead algorithm, we would be able to take care of all the health centers, all the needs of the patients there, and then in real time. We're also looking at AI in glaucoma, for glaucoma screening, the algorithms for glaucoma screening. We've come quite a long way with that. We've come quite a long way. That would be also very beneficial. Having Joseph's talking about diabetes in Malta is very popular, unfortunately. So glaucoma screening is part of the diabetes program, the diabetes screening program. And so if we manage to get that on board for us, it would be even, it will be more beneficial and quicker and faster, and we can deal with patients better in the sense that faster and in real time rather than again, there is the scare that with AI it will replace human intervention, but it's not that. It's just it helps human intervention to move forward faster, better diagnosis, and everything.
So it's back to that. So the infrastructure, the connection, and you're actually applying AI to screening, and that's how you're essentially using it across Malta. For the moment, yes, we're dealing with, we're looking at how to apply AI algorithms into screening programs that we have, which are nationwide, because primary care is the national primary health carrier. Yeah. So yes, that's how we're dealing with AI at the moment. Great. And Pierre, finally from you, I'll come to question. There's probably time for one or two questions from the audience. What is the role of government here? I mean, in Malta, Roseanne alluded to the fact it's a small nation. It's relatively easier to implement things at a national scale. But when you look around the world to places like the UK and others, what can we learn from Malta, and what is the role of government here in actually getting the spread of AI and other technologies across primary care?
First of all, I can mention that there is commitment from the government, from the AI strategy, from the digital health strategy. These are all things that are being pushed and shown commitment that there is the will to make Malta as a fronting the digital healthcare in the EU and comparing to the UK as well. When mentioning AI and all the data that is being captured, the idea, as mentioned even in the previous panel, ethics, privacy, security, these are all things that the government is looking into, creating, let's say, regulations, policies, and procedures in order to make things happen. So these are really key that when we talk in primary healthcare and even secondary, government needs to be committed, and there's also needs to be the push for the private health providers as well. Data comes in from every point. It's not only government and primary healthcare. In order to, as mentioned before, one patient record, one view, and the patient has and owns the data and gives consent and everything. It has to be all across. So government is key there to get everyone together for one common goal.
Masood and Joe, any final thoughts?
So my plea out to any supplier, anybody else here, make it easy for us to look after patients. Okay, so I'm looking for solutions now, not AI necessarily at the moment. I'm looking for augmented intelligence. Okay, I want my life to be. I want to be able to focus on the patient. Okay, not be entering data into the computer. So the sort of AI technologies I'm looking at in my practice for my staff are things that make their job easy. Get rid of the boring stuff. Okay, I don't want to do the boring stuff. I don't want to file normal blood results. I want to spend my time seeing patients. I want to sit in front of a patient and talk to them whilst everything is being captured and coded. Okay? And those technologies exist. That's the sort of things I'm looking for. I don't want other fancy things in the background. Do that for me first. Make it easy for me and my staff and my teams to look after patients. And the rest will follow. We'll deliver really good patient care. Okay? That's probably my key message. And that's what we need in primary healthcare now, rather than other fancy solutions.
Lovely.
Yeah, my final words, James. I share Masood's frustration there in general practice. I was there for 20 years. Every intervention made more work for us, right? And I'm just very keen for us all to have a bit of a mindset change here and think, I know it sounds bizarre, less medical. I think we should be looking at lifestyle. We should be looking at job design. We should be looking at city design. We should be thinking, how do we make life healthier to stop people getting into the systems that are already here? Because there's only so many of Masoods. He's a dying breed. I worry for general practice in its current status. So yeah, I just challenge you all, think differently. Let's stop sickness from happening.
But the future is bright if we get it right. Look after staff, they'll look after patients. Let's end on a positive. Any questions from the audience, or should we wrap up? Time for one, maybe? Yes, over here.
There have been for quite a couple of decades, I would imagine, remote monitoring systems for patients. And for particular conditions like arrhythmias, people with angina, people with neurological problems, I suspect that this would be a very good area to direct AI to collect data and to actually alarm people when things are going off.
It's probably one for you, Joe. Remote monitoring's a good idea for AI.
You're spot on, actually. I mean, you can create a virtual ward to, get any data in as long as you've got the API to whatever the device is, and that's sometimes a bit product restrictive. But yeah, we've spoken to people who do heart monitoring, who have wearables for, gait assessment, look at looking at Parkinson's in its early stages, prevention of falls, and it's all out there, absolutely. The connectivity is there. Applying AI to it, of course, makes sense, but you want to have a medic look at it first because you've got a person on the end of it. But you're dead right. I think, we should be looking more to wearables and looking at people in the community rather than just thinking, okay, you need to come into a place and get looked at. AI is going to pick up this stuff. But you know what? Let's have a medic look at it first, I think.
Thanks, everybody. Give my panel a round of applause.